Ahora, Dani.
Sí, ahí se escucha. Bien,
Perfecto.
perfecto.
Bien.
All right, thank you all for joining today's webinar. I will pass it to Carol to provide introductions.
Thanks, Kristen. Good morning, good afternoon, and good evening, everyone. I hope you are all well, and welcome to our webinar of September. Today we'll be hearing from our panelists, a group of amazing panelists about digital health inclusion in indigenous populations. And the team has done some case studies led by RECAINSA in Latin America and the Caribbean, and will be presenting those case studies to us today. Before I introduce our team to you, I would like to inform us all that D3, under the Mark Michel Award, is going to award two awardees a scholarship to attend the Global Digital Health Network, Forum in Nairobi this year. We have put out a call for applications. Kindly look out for it on our socials and also on the GDHN listserv, and extend it to anyone that you know, and we'll be focusing on participants from LMICs. Kindly look out for it and extend it to people you think would benefit from this. The deadline for application is the 8th. Is that true, Kristen?
September 8th.
8th of September. Yeah, that's the deadline for the application. So allow me to introduce our team lead today, who is Daniel. Daniel from who is the Executive Director and CEO of RECAINSA, to introduce his team and start us off for our webinar. Thank you.
Well, thank you very much for the invitation to the Global Digital Health Network, especially to the co-chairs to participate in this webinar. It's my pleasure to share this space with the Dr. Judit Marisa Diaz Bazán, that is a specialist in public health and is the coordinator of the projects implemented by Fundación SORMAS in several countries in Latin America, including Bolivia. She is Argentinian. She is medical doctor with master in public health. So thank you very much, Judith, for joining us, and it's a pleasure to have you here, especially because you are part of RECAINSA too, as a co-chair, as our co-chair of the Public Health Commission. Thank you very much. Stefan Escobar is medical doctor and is a specialist in telehealth and telemedicine. He works for the Ministry of Health of Peru. He's part of the team of the telemedicine of the Ministry of Health of Peru. He's also researcher in the Universidad Mayor de San Marcos in Peru. And it's a pleasure to have you here, Stefan. Good morning. Well, finally, my name is Daniel Otzoy-Garcia. I am, as Carol mentioned, I am the executive director and co-founder of RECAINSA, and I will share a little bit about RECAINSA. So today we will share some insights and results of the report that we produce about the digital health inclusion in Latin America and the Caribbean, especially focus in the indigenous population, the inclusion of the indigenous population in the design of digital health strategies. So we produce this report that will be launched in in the next few days through our social media. Please be pending on that. And we will discuss in the second moment with Judit and Stefan about this important topic in our region that, Latin America is one of the most inequitable region in the world. So I have prepared a presentation to share with you a little bit about the report that it will be published in Spanish, but we expect to have it in a very short term in English to at least a summary about this report. So I will share my screen. And please confirm me you are watching my presentation. Yeah, okay.
Yes,
Oh, thank you very much. So, well, about RECAINSA a little bit. We are a network. We were born in Central America as a volunteers network in 2013 with the intention to support our countries towards the digital transformation of the health sector, especially in the strategic layer. So from there to date, we have now all the Latin American region as a part of our work. We have participation of all the countries in the Americas. Actually, we have participation from colleagues from Canada, United States, from Mexico to Argentina, and including the Caribbean. So with this starting point that we had as volunteers, we created a NGO in Guatemala in 2021, and we complete the legal registration in Argentina and the United States in 2023. So we have 3 legal entities now in Argentina, USA, and Guatemala. And our target is continuing the organization expansion, not only in the virtual, but in the presential way too. So we are starting to work with Brazil, the English Caribbean, and the idea to have something in Europe too. At this time, we have performed programs and projects in 16 countries in the region. That is something that proves the work that we are doing in the region, and we are not more Central American, but we are a Latin American and Caribbean network. We guide our intervention based in the global frameworks, like the Global Strategy on Digital Health 2025. And that's because we perform this kind of activities like this report that we produce. As you know, the strategic objectives in the global strategy has the human-centered design as a part of that, emphasizing the need to have more human-centered health information system, digital intervention, right? Additionally, we have endorsed the 8 principles of digital transformation of public health. That is a initiative launched by the Pan American Health Organization in 2020. And these 8 principles includes several things related with inclusion, equity. For example, the third principle specifically mention the inclusive digital health. Additionally, the 5 principle mention the human right approach, and the 8 a public health architecture based precisely in this more human-centered design. So taking that into consideration, we, as I mentioned, we are a network, but we are a network of organizations and individuals. And this is important to mention because we sign a memorandum of understanding with several organizations from the government sector, from the private sector, from the academia, civil society, we interact with the donors and the main stakeholders in the global and regional scenario. So it's important to mention also that our strategic approach has 4 areas. One of them is the evidence generation for decision-making on digital transformation. And that is because we found the need to produce this report. In our region, we have approximately 42 million of indigenous people that taking into consideration the self determination as indigenous, right? This is a information provided by the World Bank. So we, in partnership with the Universidad Nacional Mayor de San Marcos, that is one of the most prestigious universities in the Latin American and Caribbean region, based in Peru, and one of the oldest universities actually in the Americas. And with the Fundación Aldea, that is a association that works in Ecuador. They are working for the health rights of the population in general, but with a special focus with indigenous population. We produce the report thanks to the support of the Patrick J. McGovern Foundation too, that they provide us a grant, a 3-year grant with the freedom to produce any kind of evidence that support our region, and with the special support of Digital Square too, that they help us as a fiscal partner in the United States. So we are, as I said, launching this report this week. Has been a extensive and long work because we are small teams and we have a lot of things to do for sure. And this is always a challenge for the organization. Small organizations are as us. But we produce this report that we are proud of this report because for us is the first report in the region of this nature with this purpose to focus in the digital inclusion, especially with the characteristics of our region, right? So it's important to mention why we do that, right? So as I said, the Latin America and Caribbean region is one of the most inequities regions in the world, right? We have income inequality, we have a limitation in terms of access to education, especially for the girls. We have huge healthcare disparities. If you live in a urban area or you live in a more local area, urban area, I'm sorry, if you live in urban or rural, this is a huge difference in terms of the access to health. In terms of employment, we have unemployment in high rates. We have a huge gender inequality, discrimination. I have to say, in countries like mine, Guatemala, we suffer in 21st century racial discrimination, even though that we have the majority of the population indigenous. We have, as I said, urban and rural divide. The political representation is very, we have disparities there too, because we don't have representation of the minorities, or even worse, as I said, in some country like mine, we don't have the representation of the majority of the population. And of course, one of the more recent divides and inequalities is the technology too, right? We have important digital gaps, especially if you are rural, if you are indigenous, if you are a woman, you have less access to the digital technologies. But well, talking about the countries that we choose, it's important probably mention before that for this presentation, I'm not including to Ecuador because the dynamic of the study in Ecuador was different than the Peru, Bolivia, and Guatemala study. We performed the multicentric study with the University of Peru and the study in Ecuador with the Asociación Aldea, and we are still processing some data from the work with Aldea. So Peru, as you know, is a country located in South America, and is a extraordinary country in terms of the cultural and linguistic diversity. It's important to mention that they have 55 indigenous groups, 51 from the Amazon, that they have an important area of the country in the Amazon, and 4 from the Andes, that is one of the most representative group in the country. This well is reflecting the 25% of the national population that identifies itself as indigenous, and communicating through 48 different languages. This is important because most of us think that in Latin America, the common language is the Spanish, but the reality is that in countries like Peru, we have additionally 48 languages, and we will see the same cases in Bolivia and Guatemala. Among them, Quechua and Aymara is one of the most predominant languages in Peru, and actually one of the most important languages in all the region, with the Quiché in Guatemala too. So with this diversity, in terms of digital, there were different approaches from several years. Actually, Peru is one of the countries with the oldest program of telemedicine in the region, with more than 30 years of practicing of the telemedicine. But given the focus of the study, that we take into consideration the language, the socio-cultural environment, especially with the indigenous group, for the design of digital intervention, there are a lot of challenges at this point. It's some initiative like Cusca, that is a chatbot, in a mobile translator to improve health communication, the more recent intervention that we identify. But additionally, we can find other intervention in the report like Teleyec, that is based in the telephone lines too, the Alin Kausei, app that is integrating also a mix of cultural approach. In the case of Bolivia, it's a multicultural country too. Like Peru is a multilingual country with 36 indigenous groups, 35 recognized languages too, and with a complex society, because we have a huge difference in Bolivia between the highlands and the coasts. According to the geographical distribution, the region is divided in the Amazon, the Chaco, and the Andes. The Andes is the highlands, and the Amazon is part of the selvatic area, and the Chaco is more the coast. As we note, with the 35 recognized indigenous language, we didn't identify digital health initiatives based in these languages. So this is important to mention because the country has a national telehealth program, at least trying to implement this program since several years ago. But this has been more a approach designed from the national level to the local level and not necessarily including the cultural or the socio-cultural characteristic of the population, right? So the most important findings is that the digital health in Bolivia is mostly or totally focused in Spanish, right? At least the documentation that we explore for the different methodologies that we use. Guatemala is characterized by its ethnic and cultural diversity too, with the 60% of the population self-defined as indigenous is the country with the most important indigenous population in all the region. Quiche is the language most used by the indigenous population in Guatemala, with approximately 1.7 million people speaking this language. It's important to mention that in Guatemala, we have 25 official languages. That is something that is not necessarily the same situation in the other countries included in the study. So that supposes a more complex situation for the government, because in theory, the government should accomplish these characteristics and this legal framework to mandatory to have these kind of approaches. Even though it's important to say that the interventions, especially from the government, are not necessary, including the Mayan languages and the characteristics of the population. Most of these interventions that are a important number of intervention of digital health performed especially by NGOs, includes mobile applications, especially for prenatal monitoring with midwives, vaccination campaigns, telehealth, monitoring of special groups of population and special group of diseases. But as I said, more focus in the labor or purposes of the NGOs or sometimes by universities. So the methodology used for the study, despite that was a methodology, a common methodology, has particularities for the country context to ensure that we cover the most important information, both scientific publication, but great literature, government platforms, and non-official sources, but with some level of trust. So we can say in the slide all the sources that we consult, right? And the results were evaluated and reviewed by 2 researchers, extracting relevant information for the study, with the selection of the detailed and most important publication about the topic that we were searching. In the case of Bolivia, was similar, the sources, as well as the repositories of the Universidad Mayor de San Andrés, Universidad Católica Boliviana, and Universidad Mayor de San Simón, that are universities of Bolivia. As well as Peru, we consulted the website of the Ministry of Health and Sport of Bolivia and other sources to get more information. In the case of Guatemala, we use the same methodology. I'm sorry. In terms of the bibliographic search in PubMed and LAC, along with Google Scholar, like in the cases of Peru and Bolivia. And additionally, we consult some specific sources from some organizations that have are of our knowledge or our understanding of the intervention that they are doing in the region. The most important conclusions is a almost 60-page report. Peru, Bolivia, and Guatemala have extensive linguistic diversity, that is evident, and that's require digital health intervention that address this complexity, right? This is something that we logically conclude, right? Guatemala has the most scientific information on digital health initiative. That was something that was a key finding, right? NGOs are instrumental in promoting and implementing digital health in indigenous languages. That is something that I mentioned. Not necessarily these interventions are performed by the government. In Peru, teleinformation, education, and communication are key components as a part of these digital health efforts. And the COVID-19 pandemic led to a significant rise in digital health initiatives, right? That is something that is reflected over the world, right? The digital acceleration during the pandemic. So that was reflected in these interventions too. And telemedicine for sure was the most common type of digital health that was incremented in this period and in the post-pandemic era. Sorry. So in general, our recommendations is promoting scientific research that analyze governmental and non-governmental initiatives in indigenous languages, and taking into consideration additionally the socio-cultural topic, because we know the cosmovision of the indigenous population, especially the biggest groups, the cosmovision that they have about the healthcare. So we cannot exclude this of the improvement of the health access as a part of the efforts towards the universal health coverage, right? We consider that telehealth is one of the strongest areas now in the region, so we need to focus the efforts there. And it's essential to develop the digital health initiative in close collaboration with the users. That this is important because commonly those interventions are designed from the organization to the population, and we need, as we have discussed many times in many spaces, to be more focused in the human-centered design approach. And probably something that is not mentioned here, but I would like to share is that most of the national digital health strategies that in the case of Guatemala, Peru, both countries have a national digital health strategy. Not necessarily are including the inclusion and equity as a fundamental pillar in the digital health strategy. Many of these strategies are focusing on interoperability, telehealth, the construction of a national EHR, but the topic related with inclusion, especially because those countries have an important group of population self-defined as indigenous, is not necessarily included in these studies. So be aware of our social media. We will share in the next few days, as I said, the publication through this. I will also share these slides for you. So thank you very much for hearing me. Probably you have a lot of questions, so we will let these questions for the third part of the session. We will now move to the discussion with our panelists. So thank you very much, and I invite Judit and Stefan to open your cameras, colleagues. You look awesome always, so no worries about the makeup or non-makeup. I don't know, Stefan, you are able to open your camera?
Yes, here I am. Good morning.
Welcome, Stefan. Thank you for the effort. We know that you are dealing with an important infectious respiratory disease, so
Yeah.
thanks for the effort to be here. And we promise that we will not force too much to talk. But this is a huge topic, as we can see. So I have prepared some questions for you guys to discuss a little bit. And the first one, if Judith, you want to start, let's talk about the general situation in the LAC region about inclusion and equity. We mentioned some topics there, but what is your personal knowledge and experience about this inclusion and equity areas for accessing to the healthcare? I don't know if you can start, Judith, and after Stefan. Thank you.
Okay. Thanks, Daniel, for this opportunity. And first, let me to express pleasure to participate in September webinar of Global Digital Health Network. Really, we know that all governments in our lovely Latin America have put in their agenda the concept of include multiculturality and include indigenous population. But maybe for me, is this only in the right works or in the law, but really in daily works, in health system, it's really very, very outside the access, not only the access in health community in the first level, maybe access in the third level to complexity, and really very excluding. For example, in my past work in Minister of Health of Argentina, when we were about to review and register all cases in COVID-19, for example, in Argentina, the Department of Epidemiology don't have put the ethnicity concepts in the file of registered cases of COVID-19. So we said, maybe we don't know if low or high impact this illness specifically. So we said, if in 19 COVID, when all resource, all human force, all law were putting on surveillance of this illness, what make an expected at other illness? So really, I said that now we have a very huge gap to let the indigenous population to access to system health.
Thank you, Judith. For sure, COVID-19 shows a lot of these inequalities and inequity, right? So, Stefan, what is your knowledge and experience on that?
I have some data related with that, and I don't know if I can project it, but if it's not, I have to say we did a first study that we have to assess the inequity in coverage of telemedicine across Peru, across the different groups of healthcare facilities. For example, we compare the coverage of telemedicine between rural and urban areas, between health facilities from the poorest quintile compared with the richest quintile, and we found some interesting things. For example, here in Peru, telemedicine have been like a bubble during COVID pandemic, but after pandemics end, the telemedicine attentions have a downfall, very increased downfall. And so now we're trying to restart the use of telemedicine in Peru, but now the use is very, very low compared with pandemic time, with pandemic period. So now we found that during pandemics, one of the main users of telemedicine, at least in a group, we have two groups in Peru. We have the health facilities that didn't do telemedicine, and a group that do. We included this group as like a national network of national telehealth network. So we have formed this kind of network, and in this network, this is a group of facilities that use telemedicine. I think it's about 3,000 facilities from the 9,000 facilities from Peru. So it's about 30%. So in considering the analysis in all facilities in Peru, we know that most of telemedicine attentions are centered in great cities, are centered in urban areas. So this, like like the paradox of telemedicine. This is some phenomena reported in studies previous, and despite that, the telemedicine should be used in people that live in remote areas. These people are the less benefited with this technology. So this is also a reality in Peru. But in this national telehealth network that is a network that constituted facilities that do telemedicine and are supervised by the Ministry of Health, the reality is inverse. The rural people, the health facilities located in rural areas develop or provide more attentions that compared to the facilities located in great cities. So this is a good news, and at least like is a model that we want to expand in all Peru. So and more the facilities located in poorest areas do more than facilities located in richest areas, in richest quintile, and the facilities located in rural areas do more than great cities. So this is an interesting thing. So we want to replicate this kind of reality in all of Peru, but we have many barriers or many challenges. I think I want to say the challenges to make this. For example, one of these is the coverage of internet in all of Peru. That this is an important thing. Other thing is digital literacy. We don't assess this, but we want to do in future. And I think that it's important if the people want to use technologies, have health and digital literated. I don't know how to say it, but I think this is very important because we want these people also could be in confidence with using technology if they know about this, the use of a phone call. I don't know if, for example, people live in indigenous population and have an experience of use a phone call, for example. So I think this is important, also an important thing to cover. And it's important also we do the second study we did is related with telemedicine maturity. So this is a study that we use the tool used for the Pan American Health Organization, and we adapted to Peru to assess what are the things, how is the level of maturity or readiness of a healthcare facility to provide telemedicine. And one of the topics we assessed to do with this questionnaire is about health users, but from the perspective of healthcare personnel. So we assess, for example, what are if there is a cultural or language barrier between users. And for example, in this topic, in this question, specific question, we have like a beginner stage. So for example, there are 4 levels of maturity in this tool. Then there are non-maturity, I don't know how to say, non-maturity. Also, the second one is beginner, the third is advanced, and the fourth is ready. Now we in the topic of cultural barriers, linguistic barriers, at least from the perspective from the healthcare personnel, users are in a beginner stage of maturity or readiness. So this is also important. This reflects, at least of the perspective from the healthcare personnel, that people is not really ready to receive telemedicine. So we have to do further activities to promote and to teach the people how to use telemedicine. What are the benefits of telemedicine? There is, for example, is a safe practice. The information should not be shared with other people. The security aspects. It's also an important thing that I think, okay, we know that we have to incapacitate, to have to inform people, but it's also important to inform or to train the healthcare personnel. I think one of the main things that we found that as a barrier for perform or for provide telemedicine is not really it's not necessarily from the user. I mean, from the user, but it's more from the provider. So, for example, many people that live in rural areas don't know about anything about telemedicine or telehealth. But I think this is the task of the healthcare provider to communicate about these services. But if the healthcare provider don't know or don't accept the telemedicine or don't agree with telemedicine, I think it will be very difficult to reach these people in these areas. So I think it's a corner important. It's a very important role of the healthcare personnel. I think if we want to start with some point, we have to start, I think, with healthcare personnel living in these areas. So I think they will work as a mediators to patients, to communicate. For example, this is also a very important thing when we see when we do community activities or we want to go we do some interventions in indigenous people. They don't have confidence in us. For example, they see us as a very different population that don't understand his needs. So I think maybe they should confidence, for example, in the community agents, or they have more confidence in the people that live in his area. So we have now to direct, I think, from my perspective, don't have to do activities direct from us to them. But from mediators, using mediators like community agents or things like that have more close relationship with them and have more confidence to start with this kind of technologies. I have to, with how you said, Daniel, and we have to start with pilot study, to try to understand what are the needs of what are the perspectives. It's like ChatGPT. When many people are very afraid from AI, from ChatGPT, and this is the same thing with them. They were afraid from telehealth. They will be afraid for these new technologies, and if there means a risk more than a benefit from them. So I think this is the thing, the approach we did. And now in Peru, we now are doing activities related with primary care. We're trying to strengthen primary care, but now as you say, we should more focus on this kind of population. There are the population that need more this kind of technology, but now how the telehealth paradox says, they are not receiving the benefit that they need. Thank you.
Well, thank you very much, Stefan. I think that was a very complete and holistic view of the Peru situation, especially the approaches performed by the Ministry of Health. As I said, Peru has one of the oldest program of telemedicine in the region, so it's logical that telehealth, telemedicine is one of the ways to reach out this kind of populations. But I think that it's important always when we work in a country to know our neighbors, right? In the case of Peru and Argentina, you guys have Bolivia too, right? What is your knowledge, Judith, about the situation? You have worked recently, actually, in Bolivia with the Fundación SORMAS, right? What is your perception of the situation of Bolivia? Those numbers that we show in the presentation reflects more or less the situation that you understand that is in Bolivia too?
Yes, thanks, Daniel. My specific expertise lies in intervention was related to management and surveillance of communicable diseases, as well as data management and field epidemiology for intervention purpose. SORMAS system was an experience relevant to the pilot program conducted in Tarija region in Bolivia. And in this context, health workers are closely connected to the medicinal practices of ancestral communities. It's very relevant for those transmissive diseases. All people have a property and own concepts about what this illness and what how can they access to answer to this illness. No, in this connection was reflected in the intervention and reference to address varying levels of healthcare complexity. The territorial context in Bolivia is given considerable attention to management by Ministry of Health and Support. Both intervention for access to healthcare have in clear relationship with a shaman or the people, men or women who know the illness of community, and maybe is in more than 70% the community go first in the first option, go to these people to answer for the illness. Maybe severe illness or only a community or more level illness. So it's very important to know this concept, introduce or put in the first step the habitual consider of what are the own concept of illness or the loss of health. Maybe loss of health for our concept is there is not loss of health condition in this habitual or in this own concepts of illness. So it's very important and was a really important experience how this system, for example, SORMAS in the pilot experience in Bolivia, can put in their language, in their habitual words, the loss or recuperate or put on the aspect of fever all unit care necessary to access for one another illness transmitted. So maybe these digital tools are very, very important to put in the register the habitual language used by community about her habitual lives and when the community lost their health condition.
Thank you very much, Judith. I think that we've found similarities between Bolivia, Peru, Guatemala, because I think that the roots are the same, right? We share some roots in the case of Peru, Bolivia. You have the Quechua, you have the Aymara, that is a common language, a huge used language in this region. We have the Mayan languages in Guatemala, the southern part of Mexico, and some parts of Central America too. But I think that one of the things that we identify in this report is the challenge to incorporate the communities, the topics that both of you mentioned, right? The socio-cultural things, the cosmovision of the healthcare of the communities, that the traditional we never, we cannot call never, but not frequently including the health strategies, and this is reflected now in digital health too. What is your opinion in terms to reach out these communities, to take into consideration this cosmovision, this sociocultural environment, to design the digital health intervention to ensure that we are not increasing the inequities and the exclusion of these communities? Maybe Stefan first and after Judit.
Yes, as I said, it's very difficult, you know. It's like different kind of communities, different kind of beliefs, different kind of perceptions about health, different kind of you know, in general, the vision of health is quite different. So in general, the development introduction of this kind of interventions in this population, it's really difficult, not just for digital health interventions, but for any intervention. So how we can sort this kind of barriers? I think, from my perspective, as I said, one of the strategies to do this is to use this kind of community agents, because we know we have this kind of I don't know if you use this this innovation curve of Rogers, you know, and the innovation curve of Rogers says that there's stages from introducing an innovation. So you have to start with early users. For example, in Peru, I don't know if in your countries exists, there is an innovation that was very, very successful, but I'm not talking about indigenous, I'm talking about the whole country. It's called this kind of yape or pling, this kind of when you share money, but using your phone number, not your bank account. You have, this is an application that with your phone number, you can share money. So this is a very usable and useful tool. But people is afraid with this. Now, most, people with 50 years and further is very afraid with share their money with a phone number, because they think that it could be robbed, or they could be scammed. So in this situation, for example, young people start using this application. So, and independent of what the bank says, that is useful, that is safe, or free, please, confidence, they don't use. And they starting to use because their sons starting using this application. So they feel more confident with the people that is near to you. So, for example, in the case of Ministry of Health of Peru, if we want to go to the communities and try to say, okay, please use digital health intervention, they don't think that we are like them. So they think that, okay, you are with your business, or say don't molest me, and we are with my own practice. We're following my own practice. But if a people that is near to them use the technology and they see them, that they are receiving a kind of benefit, independent of their belief, independent of their attitudes, independent of what they think about technologies, they at least have the curiosity to use it. Because, humans really are very emotional. So, for example, this is the reason that, for example, old women try to have decide to use the house remedies used by the neighbor instead of that the doctor says. But why? Why they confidence more in the neighbor from the doctor say? Because they feel more identified with the neighbor. Maybe it's also other women that have the same disease, and they feel, okay, you take these herbs. I'm gonna take these herbs because this. I think for this reason, I think that the community agents or the people kind of this is very important to try to be more close to these indigenous people. Instead, if we do as a minister of health, that independent of the power that we have, I think the humans not work as us. And this problem we also don't have not with the indigenous people that live in remote area. No, we have this problem with healthcare personnel. No, the person that should be trained or should be convinced that the telemedicine is important is not convinced that it's important. So we now are starting with them, with the people that should provide these interventions. And I think I think we have to include in this team also these community agents. I think healthcare personnel lives in these areas, community agents. I think there are the most important partners in the implementation of this kind of service. So this is my viewpoint.
Great, Stefan. I think that you mentioned very important topics like the incentives. Nobody does something if it doesn't have the stimulation, the incentives to do the thing. So this is very important, and thank you for highlight. What is your opinion about that, Judit?
I think that it's very important, like public health policy. We said in many countries in Latin America and Caribbean, digital health strategies are organized based on problem solving in concrete responses. For example, during pandemic, provided significant impetus for the consistent recording and incorporation of vaccination records using unified language. Additionally, surveillance of communicable diseases was strengthened through enhanced connection across various levels. However, post-pandemic, the concept of vaccine hesitancy due to either misinformation or infodemic has led to worse cover rates for routine immunization compared pre-pandemic levels. So you can say really the high level of authority are very convinced to prepare all levels of health system to answer in response to topic specific in health, and do prepare the all system to answer and facilitate the access to people to answer this or solving this problem of health. For example, we know that the indigenous population have 3 or 5 times high rates of mortality infantile. So, in fact, so it's very important to use health record digital intervention to answer and respond this problem of health. Really, if you don't see the first problem and the other problem and the impact in the health population, you can't conduce really a really health program, national or provincial or community answer like to resolve this. And it's very important, what topic to mention, Stefan. Younger population are using in like commodities, mobile phone or access to answer in the web. So all programs in health policy may be conducive to in the way to use for the health in use for better answer in the connection for facility to access a health system, like to use the mobile phone to for example for financial, for to access or one account independent of the bank only with mobile phone and use the connection directly with user.
Thank you very much. Well, probably it's important to highlight this about the fintechs and the financial sector, because interoperability is something that the financial sector is doing 30 years ago, and we are still dealing in the health sector to interoperate with the system, right? So, but that is a very good example from other sectors and highlights that the ecosystem is very important. And sometimes I think that we try to solve everything as government, right? We think that the Ministry of Health is in charge of solve everything, and now digital health too, right? Stefan mentioned something very important, that is the innovation, right? And the process of innovation is something that takes time, and the risk of failure is so high too, right? So you have a lot of startups that start with a process and is a low percentage of these startups that finish with success the innovation or the production of new approaches, right? So I think that is something about the ecosystem, how we can understand much better through the partnership with NGOs, with the innovation hubs and other important stakeholders in the country, the sociocultural environment, the anthropological aspects of the communities, and try to think in solutions, specific solutions for the communities, no matter if those communities are indigenous or not. I totally agree. But we know that, at least in the analysis that we perform, that the indigenous communities have particular topics, cosmovision. It's a cultural inside other cultures, right? It's a cultural inside other cultures. So in terms of the time and to let the audience to have some questions too, I would like to give you some minutes for your closing remarks, your recommendations about how we can be more inclusive, especially in the countries like ours that have this kind of population with a specific characteristic, as I mentioned. Probably we can start with Judit and close with Stefan, please. Thank you.
Maybe I think that it's very important to consider the government and the public health policy maybe include in their planning intervention and evaluation should also address pre-existing health and illness concepts that are deeply rooted in the cultural frameworks of each community. This action may be continuous, sustained, and measure advancement for health literacy process, but there is very necessary to adequate resource and require to ensure that personnel dedicate their time to this strategy and actively engage the community and each individual and achieving these outcomes. It's very important to put very clear to say and put in words the actions of multiculturalismo. It's very important. When you speak about don't access or gap to access in health system, maybe diversity, for example, in some countries is about diversity of sexual election, but diversity, it's very consider other ecosystem and concepts of territory, of illness, of well-being, of body and territory concept very, very closely in communities that maintain their concepts of our and proud of it. So it's very important that the government put these concepts not only in planning, but in doing intervention and evaluation about with concept of value of care of the community and put and some topics you mentioned in the beginning of your presentation about it's very difficult that in Latin America we can speak about this. We special small works or big works doing in health, but don't have access to publicity or to speak of the source. So it's a great work of the government to speak about this and put clear concepts about to address multicultural intervention in all trouble of health.
Thank you very much, Judith. Stefan?
Okay, in my case, I have to say, I don't know if my bias as a researcher, I think the first thing that you have to do is to measure. One of the things that we did in the Ministry of Health is to measure, kind of analyze data. Analyze data, for example, how many people we have to reach. For example, in the case of indigenous people, how many people is indigenous or is in this condition in Peru and where they live. For other thing, what is the coverage of telemedicine in these places? It's really bad as we think, but it's not that bad as we think. For example, in my case, as I say, we found that in general, okay, in all health facilities, rural areas where that less have less services or have less benefited with telehealth. But we found in this national health network, we found the other way around. So this is unexpected results from us. So we have, we are experts, we are, people very prepared in digital health, but we don't know how these digital technologies works in our areas. Most of the studies are developed in United States, in UK, in Canada, but it's not developed, for example, in countries as Latin American countries. We're very pluriculturally, multiculturalism. We now have to understand, as an experts, or as people dedicated in digital health, have to understand how works digital health in Peru. So how the coverage, how is the reach of this kind of services, and also complement with qualitative studies to understand what are the beliefs, what are the misconceptions that people have in these places, and try to find common things. Because, for example, in case of Peru, it's pretty difficult to try to understand one of each kind of cosmovision of each culture, because in people there are many cultures. I don't know if in other countries that is similar, but in people there are many cultures in the Amazon, there are many cultures in the highlands, are many cultures indeed in the coast. There are many cultures, people that think very different about many things. But I think we have to find what are the common things across all these kinds of different cultures that are prevented that they use this kind of technologies. So we have to do like a national national kind of intervention that could reach everyone. And I have, this partnership. I think I insist very many in this kind of partnership with the providers, because I think they are the people that kind of allow us to reach this kind of indigenous people. So this is my thing.
Thank you very much, both of you. I think that has been a very interesting conversation, and I think that is a long conversation to continue. Actually, one of the topics that probably you agree with me is that we need to produce more evidence. Stefan mentioned something that is measured. We in Latin America, we all the time are implementing things, but we never measure nothing. We don't write about the things that we are doing. And this is something that we found in this report, right? We need to produce more evidence to increase the publication about the intervention, to understand much better what things we are doing. I let you the space now, Stefan. Only want to read one question of the audience, and I invite the audience to write your questions in the chat, please. One of the questions.
Sorry,
Yeah.
just I wanted to mention the atlas. I don't know if there's World Health Organization have an atlas. So we found that atlas is empty, and we want to learn about other experiences. And it should, as you say, it's really important if others share their experiences to learn about this.
Totally, the digital health atlas, the digital health monitor. There are a lot of tools, but no. We don't submit the information on that, right? So the question is, when we are talking about digital tools for indigenous population, are you thinking to create them in the same language that they speak? And I probably add in this using the characteristic of the communities. This is a question from the audience. I don't know if Judit or Stefan, if you both want to answer, actually.
Okay, in my case, I have to say there's very promises and potentials for the future with this topic. I mean, I think the language is a very strong cultural value for any culture. So try to provide the services in their own language. I think they're very valued from them. I mean, I think it is also very important from any culture. I mean, not just indigenous, but I think if we can have the opportunity to provide the services in their own language, I think they will be very, very more confident to receive the services. But the question is how, because many people don't know about, for example, I think in Peru it's like about 35 or more than 35 languages, different languages. I think Quechua and Aymara are the most. Quechua and Aymara and Spanish also, obviously, are the more common, but I think there's more than that. But how we can reach that? I think it's very futuristic. I mean, at least from Latin American perspective. But I think that AI has a very important role or potential in this case that could provide or at least be a translator. Be a translator to reach this kind of language. I don't know if now the current LLMs, I mean, ChatGPT, Bard, have all the languages, I don't know. But I think, for example, in Quechua and Aymara, I think they have. So, for example, it would be great if we can use these LLMs as a translator to provide. So I think that's very important. It's very futuristic, but yeah, from my perspective, I think it's very important that we consider their own language to have a very better approach to these cultures.
Thank you, Stefan. Judith?
I think it's the first step. Use the habitual language or the native language, but maybe you can say it's only to translate, for example, flyer or a message in native language. No, it's very necessary sustaining the intervention that are integral to community intervention strategies for design implementation and evaluation of the program of health, not only to translate in a native language. It's necessary to involve the community in all process to consider the ecosystem and complexity to concept of health or lost condition of health.
Well, thank you very much, both of you. I think that AI, Stefan mentioned AI, is a opportunity in terms of technology, right? To have more personal intervention, right? The precision medicine is something that we are discussing, how AI can produce this more precision medicine and more personalized medicine, right? So we expect that this kind of technology help us to be more inclusive with our population. But the topics that Judit mentioned is something that we have from several years ago, right? The need to design interventions with the community, no matter if it's digital or not digital, right? Because it's not only the language, as Judith mentioned, it's the cultural, it's the relations between the different community, the different person, the different population, the different ages of populations too. The youngest people probably is more digital, more eager to explore technologies, but we have a older population too that we need to consider too, right? So we don't have more questions from the audience. I want to thank you very much, because for us in Latin America always is a challenge to speak in English, because we don't need to speak in English. I always say that we from Mexico to Argentina, we speak Spanish, fortunately, and we can share information between us without English. So sometimes it's a challenge to have a event in English. So thank you very much for the effort. Thank you very much for the audience. And I pass the floor to our colleagues of the Global Digital Health Network, saying thank you for the space, and well, be aware about the publication of the report in the next few days. Thank you very much.
Thanks so much, Daniel, Stefan, and Judith, for taking time to present to us today. There is one last question in the Q&A. They're requesting for contacts of the panelists. Daniel, if you can type them in, and allow me really to thank you for this very, very good presentation. It's very good to hear what you're doing in Latin America and the Caribbean. It shows inclusivity in our space in digital health, and we thank you so much. Please share your contacts so that the collaborations can start, because I'm very sure there are very many people that are interested in collaborating with you and furthering these discussions. To everyone who attended today, thank you so much for your time, and I wish you a great day and evening for those who are on our time zone deity. Thank you and have a great day. Bye.
Thank you.